I'm Dr. Alan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the New York community. Today's program will focus on infectious disease, how to treat them, how to prevent them, both at home and in the hospital. My esteemed guests tonight are Dr. Anna Oppenheimer, Associate Program Director of the Internal Medicine and Infectious Disease Department at Richmond University Medical Center, and Dr. Peter Stathopoulos, a Senior Attending Physician at Richmond University Medical Center. Thank you so much for coming.
Welcome.
We're going to talk about infectious disease today. And you think about what's infectious disease. So I'll talk about what's a doctor of infectious disease. So tell me a little bit about what a doctor of infectious disease is.
A doctor of infectious diseases is a specialist that treats infections, and infections that are caused by bacteria, by virus, by animals. So all sorts of infections are usually what the realm of infectious diseases is. And these doctors usually are also the referral from other physicians in the community who are faced with situations where they feel an infectious disease specialist is necessary.
So we specialize in infectious disease. So when an internist, all of us go to our primary care physician, many people go to internists. How do you decide about an infectious disease, that someone who has an infection, whether it's something that could be treated one way or needs a specialist in that subspecialty of infectious disease? How do you make that determination?
Yeah, as a primary care physician, we pretty much are the physician that people will call and come to see us for all their particular problems. So whether it's an infection or a certain symptom. But when we see infections, we have to be able to recognize and know our limitations, first of all, because doctors like Anna are the ones we refer to, especially with serious infections. If we have strong suspicions that we have a very complicated bacterial infection or a complicated viral infection, we can initiate maybe some lab work, maybe even initiate treatment, and then certainly refer to our infectious disease colleagues for further clarification and direction in terms of treatment.
And I think it's just so important, your training, the training of people in family practice, primary care physicians, internists, is just so vast. I mean, with regard to internal medicine, there's gastroenterology, there's stomach issues, lung issues, neurological issues, infectious disease. And a vast majority of people don't need to go to subspecialists like Anna or myself in neurology for care.
Yes.
I think the care is marvelous.
Yes.
So we're going to talk about some very specific infectious issues that are going on there now.
Sure.
And in the summertime, and all of us watch the news, there's been this whole thing over the last 2 or 3 years about Zika virus. And it's moved up from Latin America. It's an insect-borne or transmitted process. It's gone into Florida. Now it's the summertime in New York and mosquitoes are coming out. What kind of warnings, what could we look for? What do we have to think about with that, Anna?
So Zika actually started in the 70s. It was identified in the Zika forest in Uganda. That's why the name. And it did spread all over the world, basically. Currently, the only place that has not reported Zika yet is Europe. But definitely Latin America, South America, Africa, and it has also spread to the United States. Most of the cases are actually born outside, so it's brought here by travelers. There was just one report of one infection that occurred in the United States, and that was caused by sexual transmission.
So how does someone get Zika virus?
So the virus is carried by a mosquito. The mosquito is called Aedes, is a medical name. There are 2 types of mosquitoes that carry Zika. And they also can carry other diseases, by the way, other viral diseases like West Nile, which is another scourge in the United States and in New York especially. But they can also carry dengue and chikungunya, more tropical names that people might not be very aware of. But these are diseases, yellow fever, it's another one. These are diseases that are more common in tropical areas. So this mosquito carries this virus and bites the person and transmits the virus during the bite. The mosquito doesn't bite to transmit, it bites to feed. But during the feeding process, the virus is transmitted, penetrates into cells. Viruses are very smart, in quotes.
They know how to survive.
Yes.
And they know how to multiply.
Yes, they have mechanisms to penetrate cells and deliver their insides, usually DNA or RNA, and then they take over the machinery of the cell.
So
And
let me
that's
ask you
how
a
people
simple
get
question
sick.
from a simple neurologist. How would I know if a mosquito bit me and I've been outside near the pool, there's stagnant water all over, what would I feel? How would I know?
So usually there is a period of time where your body starts to recognize that there is a foreign body inside itself. And for that period, you might not feel anything. If, after a few weeks, usually 2 weeks for most diseases, a person might start feeling, feverish, body aches, headaches is a very common symptom of these diseases caused by virus from mosquitoes. Headaches, I said, and rash. So you can have different types of rashes. So your skin might get papery, itchy, with bumps on it, red bumps, and so these bumps can vary very much. But that's the first symptoms that actually in the beginning it looks like you have the flu.
Do most people, if say a mosquito bit me and a couple of weeks from now I had a rash and had some flu-like symptoms, should I go to my internist?
Definitely.
And most times, would my internist even know that it's Zika, or most times you would think it's just a regular virus?
Yeah, well, our physicians are very well educated. Mm-hmm. They do get updated themselves. So, and during certain seasons, they know what to look for. So if a patient presents with a rash and fever and headache, so these all are alerts, and the primary care physicians usually start having a suspicion.
So Zika doesn't have a major effect on adults most of the time, but you get the flu-like symptoms, feel like you have a cold, under the weather. Tell me a little bit what happens with pregnant women. That's what I've seen a lot in the news about.
Right. So
I was just going to say, Alan, I mean, that was a beautiful introduction to Zika. But as far as the person presenting to primary care, the Zika and dengue usually are fairly dramatic. People are very symptomatic, and they will seek to come out and see a primary care physician. So yeah, they get very sick. We several months ago in the fall saw our first Zika virus in the office, and this happened to be a young nurse who traveled to the Caribbean. And when she returned, shortly thereafter, she got very ill with severe myalgia, severe muscle aches, fever. She broke out with a rash. Matter of fact, one of our nurse practitioners were evaluating the patient, brought me in, and we did an evaluation for dengue and for Zika and all the viral infections at that time. And plus, she had the travel history. So, and she did come up with positive on her blood test. So these are fairly dramatic, and every person today should be thinking of these diseases and also taking a history of travel, which would lead them to go down that path. So Central America, South America, Mexico, or the Caribbean.
Florida also.
Florida right now is in that catch area too. That should prompt everybody to be sending out blood tests for Zika.
So people in New York shouldn't be petrified of going out in the summer, being bitten by a mosquito. It's a rare entity right now in New York.
I would not say so.
No?
Yes, last year there were about 125 cases reported. This year, though, we have about 700 cases in New York State and 250 cases in Puerto Rico, or maybe the other way around.
But there are a lot of people.
700
so we have to keep our antenna up about it. I wanted to get.
But like Anna said, these are cases that are all travel related. These are not cases that are being infected here.
So we shouldn't be petrified in New York. But I think the thing that I want to go into is a little bit about with pregnancy. If you're a pregnant woman, what restrictions would you have about going into these endemic areas or even in New York? And again, we're more of a local program here. So the idea, if you're out by the pool and you get bitten by a mosquito, should there be an overwhelming concern if you're pregnant? Should you stay inside the entire 9 months of pregnancy? What recommendations do you have?
Right. So the group of pregnant women is a little bit different epidemiologically. And the reason is the effects of the Zika, as you said, in an adult is basically a mild disease. And as you said, it varies. It can go from a very mild disease to a moderate presentation to a very severe dramatic case. But in pregnant women, besides those effects, the effects on the fetus is tremendous. So the most commonly known is microcephaly, which is devastating. Nobody wants to have a baby who doesn't have half of the brain. These babies will grow up to be adults, and some of them will be able to actually go to school. But the truth is they will have developmental...
you lose a tremendous amount of IQ points, hydrocephalus, water on the brain, small brain. I mean, this is my specialty also. The things that happen are just devastating to the child. So we try to avoid that, and again, using all kinds of repellents and other things. And the recommendations are to try to avoid some travel to those areas.
So definitely, if you are pregnant, you should not go to the countries at risk. And so the ones we already talked about. If you have vacations or weddings, one of my colleagues had a wedding scheduled, and the whole crew was in the bachelorette party, and they were all young females and in reproductive age. So, and they did change. So one of them is do not travel. Avoid traveling to these places. The other one is even if you did not travel, but your partner did, you're still at risk. So, and sexual activities should actually be avoided for at least 6 months if your male partner traveled. If you traveled as a female, sexual activity should be avoided for at least 3 months. So, and the reason is, so in the case of the males, it's because of the persistence of the virus in seminal fluids. And we don't know why.
So it can get transmitted sexually.
Exactly.
And I think it's important. I mean, we're going to not go into every detail about it, but just the idea that this time of year, that people have to be aware of trying to avoid getting bitten by mosquitoes, which we all try, but even more so in pregnant women, and also that travel to Latin America, Florida, have to be careful.
The question I would have, and if a woman presents and she's pregnant, she may have not known she was pregnant. She did travel to an endemic area. How do we counsel that patient if they come in and say, yeah, I just discovered I'm pregnant, but also I traveled to the Caribbean?
So this woman should be tested immediately. And so she can be tested with commercial testing. If this commercial testing is positive, then a new sample is sent to the public health laboratories of the local region, and they do more advanced testing and confirm or not the case. Now,
do we advise, if we're confirming that?
Yes.
Do we go ahead and advise or recommend
when you're thinking about to terminate? So, yes, this is a more touchy subject, but the public health officials are actually discussing this right now. Is it advisable, given that the outcomes of these pregnancies are very, sentimentally, logistically, physically hard to deal with? Yes.
And sad to say that even if you're able to look at a baby's head through an ultrasound test, but even if the baby's head is normal size, it doesn't mean they'll have normal development. And there's a very touchy and ethically difficult problem for a lot of people. But you bring up a marvelous point, Peter. I'm going to move on a little bit, and we're going to talk about some other topics because we have such wonderful experts. Deer have come to Staten Island. There are a lot of deer on Staten Island. And in my medical school days, deer, ticks, association with Lyme disease. And Lyme disease comes from Lyme, Connecticut, as you know, where there's a large endemic deer population. And I used to tell my patients on Staten Island, if there's no deer, you probably can't get Lyme disease, which is not exactly true, but close to it. So tell me, are we seeing an epidemic of Lyme disease with all the deer out here?
I would say that the number of cases of Lyme is definitely increasing, so it's not decreasing. And yes, you're right, the more deer, the more exposure. And you don't need necessarily to actually get close to the deer to get it, because you get Lyme from the tick that deer carry. And they can drop these ticks, and they can go to our pets. They can be in the lawns. So it just depends how close your backyard is from wooden areas where deer go and inhabit.
So if you, let's assume that you see a tick on you, and you take the tick off. What should you do with it? Should you throw the tick away? Should you take the tick to your doctor?
So it depends. Actually, I lived for a while in North Carolina,
Yes.
and which is a very hot region for Lyme as well. And so when we were moving back to New York, so we drove a caravan, and our little dog was with us. So after a few hours of driving, I feel something crawling in my neck, and it was a little tick that probably came from the dog. And so that one was not attached. So I didn't do anything with it. Also, I was in the middle of the road anyway. But if the tick is attached, and that's where the problems start, if the tick is attached, then it should be removed. And it should be removed with care. No nail polish, no alcohol, no matches, no oils. It should just use a tweezer and grab the tick by closest to the skin as possible and just yank it up. And the idea is to remove the mouth parts that are the vehicle to transmit the bacteria. Here is a bacteria that lives inside the guts of the tick, going to the human.
So the tick bites you, it gives you that bacteria.
But from a practical primary care point of view, what we always see in the office on a regular basis is someone will call, someone will say, I picked the tick off of me. And either they want to send the tick out or they want to come in and get tested, or what do we do? And given the fact that they were in an endemic area, my recommendations usually are to just treat empirically with antibiotic without bothering to do a baseline Lyme antibiotic testing and then a follow-up. Now, is that correct? Am I doing the right thing, or should we be having our patients do blood tests and then follow-up blood tests in 6 to 8 weeks?
No, you're absolutely correct.
All right.
Earlier treatment is better than later treatment. And the reason is earlier treatment actually lead to killing of the bug and probably less effects later on, because these bacteria also cause, or the reaction of the body to their presence cause formation of antibodies that can then lead to some pains that become chronic.
So tell us, what symptoms do you have with
So-
Lyme disease? Let's go to the beginning. If someone has a tick bite and they do get Lyme disease a few weeks later, what are the first things? Tell us about the rash and the muscle aches and
Boy,
the
you
joint
know
pain.
what? I think it's such a Lyme's is such a great imitator of so many presentations. From my experience, has been from simple fatigue with no rash to a classic rash, which is obvious to the patient. They come in and they've already made the diagnosis.
And what is the classic rash?
Well, we call it erythema migrans. It's a target lesion, a bullseye.
Bullseye.
There's central clearing, and it's fairly classic. But I'm not sure, and I think 50% or 60% of people are infected may not present with
the rash.
with the
correct.
rash. So, you know, when you really can't depend on that. So otherwise, you'll be missing a lot of Lyme disease.
The other thing is that early in the disease, tests actually do not help, because they may be negative since the body is still trying to
Produce antibodies.
produce
Sure,
antibodies
sure.
to it. So the tests are going to be negative. The tests are going to be helpful later on, 6 to 8 weeks later. Then you test, and if they're positive, you'll say, okay, I was right on my diagnosis, and I was right in treating this patient.
Yeah. I had an interesting case last summer where a gentleman had traveled down south to see family, and when he was down there, he developed severe neck pain with neuralgia. He was seen in a university center. He had the MRIs. He had a very thorough evaluation, and there was no diagnosis made at the time. Came back up, and when he presented in the office, very ill-looking, and still persisted with the symptoms. Going into a little detailed, trying to get some information out of him, he was upstate for a while. So along with all the testing, we also threw in a Lyme's antibody testing. And fortunately for him, this made the diagnosis, and we were able to treat this gentleman with antibiotics, at which point we had our infectious disease doctors, we had our neurologists get on board to determine what would be the appropriate amount and whether we should treat intravenously or orally. That was
There are different kinds of antibiotics to
sure,
use for
sure,
different
and
things.
yeah.
But that's what's so important about the history.
Yeah,
Travel history,
Travel
getting
history,
the kind
yeah.
of things in order to know where someone's been,
Yeah.
what they've been exposed to.
sure. And on Staten Island today with the deers, certainly years ago, it was always someone was in New Jersey or someone was in Pennsylvania or someone was in Connecticut. Today,
It's
we know because of
Local
the deer
cases.
population that we're getting our Lyme's disease transmission, and people are getting ill here on Staten Island.
And as a neurologist, I see so many patients with Lyme disease with so many different symptoms. Some that mimic multiple sclerosis, some that mimic pinched nerves, numbness, tingling, some very non-specific symptoms, headaches.
So would you put that, do you also, with your workup, always put a Lyme test?
Many a time.
Yeah, yeah.
I mean, it's really there in the differential diagnosis, which means that we look for what things someone might have, and they could be a list as long as my arm, but we usually think about Lyme disease in most cases too.
One of the cases I had last year, so he was from New Jersey, had a farm, loved the outdoors life, dogs, family, everybody was an outdoor family. And he had some redness in his skin. So he went to the primary care. Primary care treated him twice for cellulitis.
Cellulitis is an infection of the skin.
Yes. So there are mimics. So you're talking about neurologic mimics, and those are infection mimics of it. So, and I said, well, show me the cellulitis. And it was in his trunk, and it was so clear. I said, this is Lyme. So we had a long discussion about Lyme and about avoidance of deer, and because of the place he lived. And he said, okay, I understand, but I won't move. I love my life, and that's where I'm going to be.
Let me ask you something just in general medicine. So many of our patients come in with pictures now because of cell phones, smartphones.
Sure,
Do you like when people come in with pictures?
You know, I think it's good for people to educate themselves. I think sometimes what ends up happening, though, they go into a website, and inherently, once you start reading about a particular situation, it can become very confusing, and the information can be overwhelming to the average person without a medical background.
I'm actually talking about pictures of yourself. If I have a rash on my arm and I take it with
Right.
my own phone,
Oh,
bring it in.
You know what? I think that's great because I've had people do that, and a lot of times you can make the diagnosis.
And I am
Diagnosis.
thrilled when people
Yeah,
do that.
yeah.
I love it.
And
I-
especially as a neurologist, people have
Yeah.
unusual movements that you sometimes see.
Sure,
They
sure.
take short videos of
Yeah,
it. I think
yeah,
it's remarkable.
yeah, it is.
I'm going to go over, we're running a little bit low on time, so I'm going to go over one other topic that I think is really important for us to go over. We all work in a hospital. We all work in different places. People are so concerned about going to the hospital and getting an infection in the hospital. People say, wow, if I have chest pain, I'm not going to go to the hospital because I'm going to get sick there. If I need surgery, what do I do? I'm going to not do it for as long as I can because I'm so concerned. What concern should our audience have, and people in general, when they walk into a hospital? Should they be comfortable at the sterility of the hospital, whether it's in the operating room or on the floors? Someone's coughing in the room next to you. Should you bring your own little bleach wipes for the bathroom? And I know Annie works a lot in the hospital. Tell us what would make us feel comfortable.
Hospital-acquired infections, HAI, that's what they're called. And yes, it's a big concern, and it's not it's a concern for the people who use the hospital, and definitely for the people who work in the hospital and for the administrators of the hospital. It's such a big problem because, so infections can pass from one person to the other. That's true. And not just that, but also infections with more resistant organisms pass.
So stronger bacteria, stronger
yes,
bugs are in the
yes,
hospital
and
because
some-
we have people who are sicker.
Right.
And so what could we do to make it safer in the
Well,
hospital?
first, I think I should point out, because I do work in a hospital, is that the concern is such, and the Department of Health and the Joint Commission and other organizations that norm hospital functioning are also looking at that. So the hospital takes lots of measures to make sure that the rates of hospital-acquired infections are reduced. And this goes by, cleaning the rooms after each patient comes, and they use ultraviolet light, they use bleach, making sure that isolation signs are obeyed, that everybody washes their hands. Washing hands.
It's crucial.
So soap and
Crucial.
water, right, Anna?
Soap and water with everybody, nurses, aides,
Right.
patients, families, visitors.
Right.
So it's very, very important.
So if you're in the hospital and someone walks into your room and doesn't wash their hands, whether it's a doctor, a nurse, should you tell them?
Yes.
Yes.
A patient can say, "Did you wash your hands?"
Sure.
Yes.
Wash your hands going in.
Please,
Wash your hands
yes.
coming back
Absolutely.
out.
I mean, the
And
importance
even
of
if you're
taking care of
wearing
yourself.
gloves, Alan,
Yes,
too.
yes.
If you wear gloves, when you take off the gloves, wash your hands.
Yes. So as a teacher of residents, so one of the things I do, so I go into a room, and sometimes you can't wash, so you use alcohol rubs, right? So you,
The Perel,
you rub
those kind
it,
of-
Yeah,
exactly.
and that's
So
available
you
all
rub
over the
it,
hospital.
Yes, and then I look back to see who is doing it, right? And I'm like, did everybody remember? So, and they go and they do it, because it's a learning, thing.
Yeah,
so
you get into a habit where you start doing that.
And we're winding up, actually. So
Yeah.
to talk about how, just to end that topic, you have to be involved in your own care. That if you're in the
Definitely.
hospital, if you see someone coming in with dirty hands or they didn't wipe their stethoscope, you really have to be involved. With that, I'm going to say thank you to both of you for being
Oh,
here.
our
The
pleasure,
half hour
my
goes by so
pleasure.
quickly,
It does.
and we'll have to do it again soon. I mean, we've learned so much, and there's so many other topics in infectious disease, and I want to thank you all. It's been a pleasure to be
Thank
with
you
you
for
today.
inviting
thank
us,
you,
Alan.
thank you.